Hi, Block One. This is Marcel back to talk to you about med-surg nursing. And then part two of this will be who's who and what do they do. So on the first slide, you have the practice of nursing in today's healthcare delivery system. So there's some different statements that are available to you out there. I put some links too for the American Nurses Association if you wanted to join. I have that. So in my office, you can come in and read any of the little magazines I get every month that have some interesting things that are happening in the world of nursing, just to keep you apprised of new policies or new happenings in technology and patient care. Then the Nursing Standards of Practice, or the State Practice Act. So one thing I think it's important for you to know is that every state has their own Standards of Practice or State Practice Act. So if you were to obtain your license in Arizona and then you decide I'm going to go work in California, it is your responsibility as the nurse to know what their practice standards are. So, for example, a lot of things that are changing, I would say, would be like the LPNs. We are now having more LPNs working in the hospital setting. So their scope of practice is changing as we allow them to do more things than they typically would have been allowed to do. So it is the responsibility of the RN who is over the LPN's practice, as well as the LPN, to know what is within their scope of practice. Because if you were to perform a skill that was outside of your scope of practice and you made a mistake, that is not going to go well. So you have to look up and be familiar with each state's scope of practice if you're working in that state. Then you have the Code of Ethics, which is, I put an article out there for you to read, and it does include a lot of those different words which you are going to be responsible to know on your first exam, which are like beneficence and fidelity and off the top of my head, I can't think of any more, but there's probably several, and you will need to be familiar with what those are. I will say that nursing is a profession, and as such, it requires us to act professionally in all situations, so it doesn't just apply at home. So if you were to have a domestic violence situation in which you got arrested for, or if you were to get a DUI, you could lose your license over that, even though you were not at work, because we're held to a higher standard because we are in a profession. Okay, next we have med-surg nursing. So what is that? It is a specialty area of practice, which I believe that Wes has his certification in med-surg nursing. It's a great place to start out to get a general overview of nursing, because you're going to see a lot of different things. So for example, you're going to have patients that just had surgery, as the name suggests, but you'll also have patients that don't necessarily have to be on a heart monitor, but maybe they have pneumonia, or maybe, I don't know, I'm trying to think what else could have happened. They fell and broke their hip. You'll see a wide variety of patients on the med-surg floors. So you get a lot of exposure and experience in learning how to assess those patients and identify what you need to do using the nursing process, so that if you ever leave that setting, you are really well prepared to go and work somewhere else, because you've seen all the things. Let's see. And at the bottom, there's a link for you to look at joining the Med-Surg Nursing Association. Critical care nursing is just what it sounds like. It's like ICU. So you're working in a critical care unit. You only have a couple of patients because they are acutely critically ill, and you will be doing a lot of things to keep them alive. That's all I'm going to say about that. But they also have a membership, American, I forgot what that stands for, American Acute Critical Nursing, something like that. Rehabilitation nursing. So this is a lot of what you're going to see in Block 1. And we holistically provide services to patients that have been incapacitated by illness or injury, and they're facing maybe life-altering health conditions. So, for example, 86-year-old develops pneumonia, goes to the hospital. they lay in bed for 4 days while they get IV antibiotics. They're probably going to rehab after that because they are already weak. They've lost muscle mass. Now they've laid in bed for 4 days. So they're deconditioned and they need to go to rehab and work with physical therapy and occupational therapy to regain, hopefully, their baseline of where they were before they were in the hospital. That's always the goal. Get them back to their baseline. And if we can't do that, then can we get them to the point where they're able to return to where they came from? Can they go back home? Can they go back to their assisted living? Or do they now have to live in long-term care because they're not going to be able to do their own ADLs, which are activities of daily living, if you're not familiar with that term. So that's a lot of what rehabilitation nursing is all about. We can do that in the home setting. So if the patient has someone at home that can take care of them and they don't want them to go to skilled nursing, then they can go home and home health can come in and provide those services. So whether that's a nurse who's coming in to educate them on a disease process or it's physical therapy or occupational therapy, we can have that set up to come in home health. But it all depends on what is going to be approved by their insurance. And then there's the rehab nurse organization if you wish to look into that or just check out the page. Here we are with home health nursing. So this area of nursing, I want to give you a disclaimer right now. A lot of people, and probably many of you listening to this video could include yourselves in this, think that home health means I'm going to have someone come in and take care of my loved one 24/7. And that is not what home health is, unfortunately. Home health is different medical professionals are going to come in according to your needs and spend a little time with you. But you need somebody there who can assist you and take care of you. So if someone is not able to take care of mom, so they might need to go to long-term care, or maybe they have funds available and they can hire a private caregiver. But we do not, home health does not include providing someone with 24/7 health care or, just like having a CNA on site. They might get a CNA to come in 2 or 3 times a week to help with bathing, but they're not going to be there to do 24/7 care. So home health is a really cool area of nursing, and it takes care of patients in all age groups. And you're going into people's homes. It's part of an interdisciplinary team. So it's, you're going to have social work, you're going to have physical therapy, occupational therapy, respiratory, nurses, CNAs. So it's just that it's in a different setting. So there's a lot of different settings. And then it says telehealth is a fast emerging piece of home health nursing. And I could see that. Maybe you work for a home health agency and you need to educate the patient on their disease process and changes they need to make in their lifestyles. Or maybe it is they just got diagnosed as diabetic and you need to teach them how to do their insulin and make sure that they're checking their blood sugars, and you're going to go over that with them and see how they're managing them. That would be something you could easily do over a telehealth visit. So there's some different links for you to check out for home health organizations. Then I put this screen print in because I think it's very important that we also look at not only what are we doing for our patients, but what are we doing for ourselves. So if you are ever going to work in a setting that requires you to go into someone else's home, there's some things you need to be aware of. So one is you're a guest in their home. So we don't just ever walk in without knocking and asking permission to enter and all of that. But here's some safety precautions in home health that I feel like I do most of these things, but you definitely want to be aware of your surroundings. You want people to know where you're going. Now, you can't give out HIPAA information, but for example, I work for Hospice of the Valley and they have an app on their phone that I show that I'm in a visit and it shows where I'm located in GPS. So they know where I am. So it's just important. Always have emergency numbers programmed into your phone. Carry your identification card with you and wear it. Make sure your phone's charged. Know where the patient lives before leaving. Keep your car in good working order and have sufficient gas in the tank. Absolutely. I drive all over the place, so don't drive an expensive car or wear expensive jewelry when you're making visits because you may not know the neighborhood you're going into, and you don't want to be driving a BMW and wearing a 5-carat diamond ring. So I drive the car that I have. I don't have a hoopty car that I can drive. So I just drive my regular car, but I'm just very aware of my surroundings and I lock my doors. Let's see. Try to visit during daylight hours. I work nights, so that's not possible for me. If you do not feel safe entering a patient's home, leave. And I cannot stress that enough. Trust your instincts. They're innate and built into you. So don't be like, oh, I'm just being a little overly sensitive. Trust them. You can always call and ask for someone else to come out and visit with you if you're feeling uncomfortable. And if someone's intoxicated or hostile, leave and reschedule. If there's an argument or someone's abusing the patient while you're in the household, again, leave. Contact your supervisor and report the abuse to the appropriate authorities. I just thought that was a good thing to know, because we talk a lot about taking care of others, but we got to talk about taking care of ourselves too. So part 2 of this is going to be who's who and what can they do. This is delegating and responsibilities for nursing students. So nursing assistants, you're going to have questions on your exams, and you're going to have these things happen in real life. We're going to give you a sheet that gives you a list of action verbs that you would know. Looking at that, that's not the role of this person, or the person that's in this role. They can't do that. So nursing assistants, it doesn't say CNA because not all nursing assistants are certified. I typically do say CNA, but not everyone working in every situation has certification. So what do? They help with ADLs, basically. They cannot perform assessments. So if you see assessment anywhere, they can't do that. They cannot make a nursing diagnosis. They cannot administer medication, complete treatments. They cannot do wound care. They cannot practice outside their scope. I mean, no one's supposed to practice outside their scope. That applies to everyone. Then you've got your LPNs. That's a 1-year full-time education program or 2 years part-time. And it's focused on the basics of nursing care. So what you want to think is, my LPNs can take care of patients that are stable. So they cannot start or stop anything. So if you are admitting a patient or discharging a patient, they're not allowed to do that. They cannot initiate restraints or discontinue restraints, but they can put on and take off restraints to make sure that they have range of motion and that their skin looks okay. So they just can't start or stop something, but they can continue something once it's started, if that makes sense. They can do reassessment, but they don't do the initial assessments, if that makes sense to you. They also can do some IV things, but they cannot do certain medications. So they are totally an asset to the healthcare team, and we have a lot of them now in the hospital setting, because they used to work in the hospital setting, and then when everyone was going for magnet status, part of that was that your nurses had to have a bachelor's degree, and it was a certain percentage. So the hospitals got away from having LPNs in the hospital setting. But now that we have a shortage in the healthcare setting, especially in the acute care settings, we have more LPNs. You will also find that many of our nurses in the long-term care facilities are LPNs. Nearly everyone is an LPN that works there in a nursing role. Many times the only RN on site will be the director of nursing. So for that reason, when you are taking care of your patients in the long-term care setting, you have to do it with your instructor, because your instructor has at least a bachelor's degree in nursing, and they are the ones that need to work with you to be passing medications or to be placing a catheter in a patient or to be performing wound care. The exception to that is when you are with the wound care nurse, sometimes they let you do wound care. But the rest of the time, you need to be with your instructor. And if your instructor tells you you can pass medications with the nurse, I would question that, because it's not in their scope of practice. And it specifically states that we are supposed to be there when you're passing meds. Let's see. This is more on that, and I probably already covered some of it. Oh, if they find some abnormal assessment or a change in condition when they're doing assessments on a stable patient, the RN has to come in and validate that assessment. And then anything that needs to be updated in the plan of care has to be reviewed by the registered nurse. So again, we start the plan of care, we end the plan of care. They can update the plan of care, but the RN has to approve that update. They have to work with the nursing assistants and the registered nurses. It's a great team. And then this kind of goes along with when you have an assessment that's abnormal. If the condition of the patient has changed, they notify the RN. And they have to work in their scope of practice, just like everyone else. So they, again, cannot begin the admission process, initiate or terminate the nursing plan of care, administer certain medications, accept verbal orders for things outside their scope of practice. So let's say that you're putting your patient on a pain pump because their pain is not controlled with oral medications or giving them intermittent IV injections. So now they're going to be on a patient-controlled administration of pain medication. So they cannot accept orders for that. It has to be the RN because it's out of their scope of practice for them to touch that pump. So that's just an example. They also, cannot accept verbal orders outside their scope of practice, kind of the same thing. Initiate or terminate patient education. So if you were looking at a test question and it said, which of these things can the RN delegate to the LPN? If you saw, educate the patient on how to give themselves an IV injection, a sub-Q injection of insulin, they cannot initiate that. So if it said, reinforce the education on how to give a sub-Q injection, they could do that because they're reinforcing what you've already taught them as the RN. So they can reinforce, but they cannot initiate or terminate. They also are not supposed to work with unstable patients, and they can't discharge. I think I said all that already. So registered nurses, we have a variety of educational backgrounds. So, we can, I don't even know. It says it's already discussed. I don't know. I wasn't the one to discuss it. I'll just tell you. You can get your ADN, which is what you're currently doing here. You can get your bachelor's degree. You can get your master's degree. You can get your advanced practice RN degree, which makes you a nurse practitioner. There's so many things you can do education-wise. I would tell you that if you want to specialize in a given area, like psych nursing, as a nurse practitioner, make sure you're taking a psych nurse practitioner program because they require specific courses. And then also there's the CRNA, which is the certified, there's like the clinical specialist nurse that's certified. There's, you might want to be a nurse anesthetist, get really good grades in nursing school if you do, because that one's pretty competitive to get into. They probably have one of the highest salaries in nursing. So we are responsible for the patient's care. So anybody that works with us, whether it's an LPN or a nursing assistant, we're responsible for everything that they do and what we do. We can delegate tasks within the scope of practice to those people. So we not only need to know our scope of practice, but those that work with us. We review data that's obtained. So let's say the nurse assistant comes and says, here's the vitals and the blood sugar. Well, we need to review that. Or maybe they don't tell us, it just gets uploaded to the chart. We need to review it. We are also the ones that notify appropriate people when needed. So if we need to call the doctor for a new order, or if we think that the patient needs a consult with the specialist, we can contact the doctor and say, hey, can we consult cardiology? They'll give you the name of who they want you to consult, and then you call them to notify them that there's a consult for them to come in. So we do a lot of phone stuff. We also contact the families with updates. Or take phone calls when the family calls us. It's a lot. We do admission assessments and initiate the plan of care, and we work within our scope of practice and institutional guidelines. So advanced practice nurses work in a variety of settings, lots of different titles. In Arizona, there is an area in the State Board of Nursing where you can look up the scope of practice for our APNs, which is advanced practice nurses. They differ according to what state you're in greatly. So if you become a nurse practitioner in Arizona, you can work independently. So you don't have to work with a physician. But if you move to Texas, you have to work under a physician. That's just an example, and that could have changed, but I know that was the case when I was in school. So you definitely want to look at the scope of practice for whatever position you're in before you make any big moves. And they do have prescriptive authority, which means they do, I'm trying to think of the word, diagnose patients with their illnesses and prescribe medications. So that's unlike an RN. RNs take what their medical diagnosis is and they treat it holistically through the nursing process, which you're going to learn more about. And it takes a while to get it down. But we don't ever say the nursing diagnosis is diabetes. The nursing diagnosis is not at all that. It's related to the diabetes, but we're treating what we're seeing symptomatically. And then clinical nurse specialists, they typically are the nurses that are doing patient education, or maybe they are the nurses that are doing the wound care. Physician's assistants have a master's degree. They do work under the scope and supervision of a physician. And so their orders have to be signed by the physician that they're working with. They have prescriptive authority too, although I think there are some class of medications that they're not able to write prescriptions for, and they can work in a lot of settings. Student nurses, I want to make clear to you that the whole time you're in nursing school, it's imperative that you do not ever identify yourself as a nurse. You can be like legally in trouble, super in trouble. Make sure that you always identify yourself as a student nurse. And you can perform tasks that we have validated in the skills lab. So you're going to be learning in block 1 how to safely pass medications orally, enterally, sub-Q, intermuscularly. You're going to learn how to insert a catheter. I'm sure there's many things you're going to be allowed to do, but you have to be checked off and validated that you know how to do those skills before you're allowed to do it in the clinical setting. So, for example, if you go into a room, you go in and say, "Hi, my name is Marcella, and I am a student nurse with Mesa Community College, and I would like to obtain a set of vitals and check your blood sugar. Is that okay with you?" And then they say, "Absolutely." You can do vital signs and blood sugars once we've trained you. There's no checkoff for that. You can also go in and change an occupied bed or put somebody on a bedpan. But anything that's going to potentially be something that will be a patient safety issue or could have adverse outcomes, you must be validated in the skills lab before you get to do it in a clinical setting. So make sure you're practicing your skills for your checkoffs, because if you don't pass them, you're not going to be allowed to do it in the clinical setting. So practice, practice, practice. Oh, and it does say back there, I want to point out again, you cannot perform any tasks with the licensed practical nurse. So you can't pass meds with them. You cannot put in the Foley catheters with them. That requires that you have your registered nurse clinical faculty validating that. So here we go. Inform the registered nurse and the instructor immediately if you see that something is going on with your patient that you're uncomfortable with, or if you witness anything that you are not comfortable with. For example, we had a situation where a student witnessed a nursing assistant putting her hands onto a patient and physically pushing them down on the bed, but she didn't say anything. And when we finally saw it in the journal entry for the student, we reported it to the director of nursing for that facility, and both that facility and MCC ended up paying a fine because we did not report it within the timelines, which I believe is within 2 hours of the occurrence. So it's important that if we see something, we say something, and you need to say it. If to no one else, say it to your instructor so that they can handle it. But I would say your director of nursing needs to be aware in the facility. So following your chain of command, it would be your nursing instructor, and then make sure that it goes on up the line. We do document all of our care interventions in the clinical agency, which we'll be showing you how to do that. We do it in our own documentation system, which is outside of theirs. And then we're going to follow the high power model. So always keep the patient information confidential. One of the things that you'll find is a lot of the places will tell you that you're able to cut off the patient identifier information and then take the charting, print it out, and take it home with you. It happens a lot in the hospital setting once you get to blocks 2 through 4. We do not take that out of the building. So it will be your responsibility to look at the charting, typically with your instructor in block 1, write down the pertinent information while you're on the nursing unit, and then you take that home and write your plan of care. Ask questions. Don't take any photos of your patients. Really, I encourage you not to take any pictures at all in the patient care areas. So it's fine to take pictures. Let your instructor take pictures of your group, either in the front of the building or maybe in the hall, like before you go into the care areas, but don't take anything in there. And make sure you maintain professional boundaries. Don't, give somebody your phone number. Don't say, I'm going to come in and visit you, because I know you don't get any visitors. It is hard, but we have to have those professional boundaries. So, you think the grandson of the patient that's visiting is super cute and he's flirting with you. Keep those professional boundaries. Find somebody else to date. So here's an example of your introduction. It says, make sure you identify yourself as a nursing student. Say it's Mesa Community College. Don't say MCC. They don't know what that is half the time. And then if the patient declines, thank them for their time. Tell them it was nice to meet them, and find another patient to work with. And then privacy. We always provide privacy as good as we can. Keep curtains closed. And we do not discuss patient issues in open settings. The second P is being present. The patient is your focus. O is offer yourself. So what that means is kind of going back to being present. It's not about you. The patient comes first, but offer your expertise and assistance. Allow the patient time to ask questions before you complete tasks. That says competing tasks, but it's supposed to be completing. And then O is check orders. Remember, not everything will have an order. All medications, treatments, and diagnostic tests must be ordered by the prescriber. So before you go giving meds, that's part of your checks. You got to make sure there's an order for it, and that it's the right time, the right dose, the right patient, the right route. I don't know, there's 6. Wash your hands. Wash your hands. If you get a test question and there's anything about hand hygiene and the answer, that's probably the answer. Because I will tell you that if you stood outside of a patient's room and watched how many people don't wash their hands when they come in or leave, you would be kind of amazed. And you may find that you yourself will get busy and forget to do it, but it is the main way we break the chain of infection. So it is the most important thing we do to keep our patients safe, I would have to say. And then work efficiently. Make sure that you have everything you need before you go into a room, especially if they're on contact for anything. You just got gowned up and gloved up and you put on a mask, and now you went in there and you don't have what you need. Like if you're going to change the bedding, you forgot the pillowcase, or you needed chucks and you didn't grab them. You're not going to take all of this stuff into a contact room, by the way. You're going to leave your stuff outside the room. So we're not bringing our pen light in there and then taking C. diff out of the room to the next room. So we don't allow smartwatches to be worn during clinical, nor do we allow them during testing. Okay, and then explain to the patient what you're doing and why, and allow them to ask questions. So if you're not comfortable talking and communicating with people you don't know, I recommend that as we are learning these new skills, practice them on people you do know and that you are comfortable with, so you kind of get the lingo down. So when you're going in and you say, hi, I'm Marcelle and I'm your student nurse from Mesa Community College, would it be okay if I took a set of vitals and got your blood sugar this morning? They say yes. Then you kind of hit it off and you're talking. You say, I have to pick a patient and I have to do a head-to-toe assessment. Would that be okay with you that if I completed it on you? And they say yes. So as you're doing it, you're like, I'm just going to check your skin to make sure that you don't have any skin breakdown. Do you have any problems with your skin? And then let them tell you. And then now I'm going to check your eyes. Can you tell me how many fingers I'm holding up? And they tell you, just that. I'm looking in your mouth to make sure that you don't have any sores or, that your mouth is moist. Do you have dentures? Yes, I do. Do they fit right? No, they don't. What kind of diet are you able to eat then? So you just kind of start talking to your patient and getting information. And then exemplify the profession, act professionally, be a role model, maintain your patient's dignity. So part of that is when you first start changing wounds or you are changing bedding, watch your facial expression and try not to, get a look of horror on your face when you look at the wound that they have on their foot or something. We're going to maintain their dignity and treat them with respect. And then follow the professional standards of Maricopa nursing. This one is really for your self-care. Raise the bed up. If you don't raise the bed up, you're going to hurt your back. So you want that bed raised up to about your waist, not your waist, about your hip line, between your hip and your waist, because then you're not bending incorrectly when you are moving your patient. Believe me, it only takes one time and your back will never be the same. So put the bed up. And I think that was the biggest thing I always forgot when I was a new nurse. You're in a hurry. You go in, you do what you need to do, you get out. I would either forget to raise the bed or forget to lower the bed. Please don't be mean. Lower the bed. If you leave them, 6 feet off the ground and they get out of bed and fall, that's not cool. And then review what you're going to do or what needs to be done and make sure that what you do is the correct procedure. Teach your patient what you're doing. And note what you completed during your shift and give yourself credit for the skills that you practiced. And if you don't know or you're unable to assess or unable to do something for your patient, reassure them that you will follow up with them. So if you say, I've got to go ask a question of my clinical instructor, but I will be back as soon as I talk to her. Or reassure them that you totally know what you're doing. And if they say, is this the first time you've done this? No, it's not the first time I've done it, because guess what? You practiced your skills over and over and over and over again in the clinical setting or in the lab. So here's some other services that you will work with interprofessionally in your nursing career. And you really kind of need to know what they do, because you have your own scope of practice and so do they. So you don't want to be doing their job too. Let them do their job. So if you see that your patient's having issues with their ADLs, maybe they don't have the range of motion to brush their hair, or their hands are so, I don't know, I can't think of the right word, but their hand is shriveled inward because they've had a stroke, and so they can't brush their teeth effectively. Who do they work with? They work with occupational therapy. Occupational therapy helps with their range of motion, helps them get modifications like a large handled spoon to feed themselves or a large handled toothbrush so that they can get a better grip on it. They work with them to make sure that they can do as much for themselves as possible. So if your patient can do it, they should be doing it. Don't do it for them. They're there to do for themselves and to regain their independence. Physical therapy works with mobility issues and wound care. So physical therapy, your patient is recovering from a stroke and they have right-sided weakness, not paralyzation, but weakness. So physical therapy is working with them on learning how to transfer from the bed to their wheelchair or how to use the walker effectively. And they're doing exercises with them to improve their mobility and their strength. Speech therapy, let's say you go in and you notice that your patient coughs a lot when they're eating or drinking. That should be a little warning sign to you that, wow, my patient might be having difficulty with swallowing. Maybe they're swallowing it into their lungs instead of into their stomach and through the esophagus. So if that's the case, we want speech to work with them because they're able to identify and work with speech and swallowing disorders. Respiratory therapy is just what it sounds like. They maintain lung function. So you will work with respiratory therapy. They'll come in and put your patient on a BiPAP or a CPAP, or they're the ones who come in and intubate your patients when that's needed, unfortunately. Or they'll just come in and give them albuterol treatment because you heard wheezing in their lungs and their oxygen saturation was 88 and it's usually 95. So a lot of the things they do, we can also do, but I just didn't mean to do that. But we work with them and they do a lot of it. And they are a great resource, trust me. The nutrition therapy. So a lot of times we need nutrition. So why do you think we have skin breakdown or fragile skin in our older patients? A lot of times it just goes hand in hand with nutrition issues. If you're not eating the right foods or in the right amounts, you'll see it in people's skin because the skin is our biggest organ. So it's probably not the only one that's being affected by that nutrition, but it's the one you can easily see. So nutrition can come in and help educate our patients that have overall nutrition issues of not getting enough calories. But they also can come in and talk about different diets. So let's say your patient is high cholesterol, high blood pressure, and now they have coronary artery disease. So they have to go on a diet that's going to restrict their amount of sodium and calories as well. Maybe they need to lose weight and watch their sodium. So nutrition can come in and talk to them. The patient doesn't do what they're supposed to do. So they have this coronary artery disease. And maybe they also had diabetes. So they need education now that they have to reduce their amount of carbs that they're eating. And they have to watch their sodium. But they don't do that either. So they come back in 6 months from now in kidney failure. And they're going to have to go on dialysis. So now they're on a renal, heart, diabetes diet. So I think it's important to educate your patient that these are the things you need to do to stop the progression of this disease that you have and you will continue to have. But if you don't do what you're supposed to do, these are the things that can happen. So, I mean, not to scare them, but to really educate them that we're looking out for their long-term health goals. So we want them to understand that if they don't make the changes that they need to, they're going to have even more restrictions. So that's what nutrition can come in and do for you. Then we have case managers. They really work with insurance to make sure that insurance is going to cover the care that they need. And then they also help the person get insurance coverage when they don't have it. So the case managers, let's say that we've determined that they are a big part of the team when we're working on discharge planning, which I've said before starts before the person's even admitted. They walked through the door of the emergency room. We're already thinking, how do we discharge the patient? So we need to discharge safely and make sure that they aren't going to be readmitted for the same reason because we didn't take care of it. So we take care of it. We make sure that they're going to be good and we get them out of there. But maybe they're still pretty ill and they have to go to skilled nursing to get some physical therapy, or they need to go home on home health for some patient education and wound care. The case manager is going to work with you and work with the physician to make sure that there's no gaps in the care for the patient, because that's the biggest thing, and that their insurance is going to cover what we are trying to do for them. So that's that. And then your social workers help look for available community resources. Make sure that you know they are not your mental health providers. So they are there to look for available community resources. Maybe that entails Meals on Wheels, or maybe it is your patient has dementia and the caregiver is super burnout. We'll get social work involved to look for daycare programs for people with dementia. So that's what your social worker does. And know the difference between your case manager and social worker, because I hear a lot of people using those terms interchangeably. They work together, but they have different roles. Thank you. Hopefully that wasn't information overload. I will see you in class. bring your questions that you have.